Hi, everyone, and welcome to today's webinar, The Benefits of In-House Lab Screening for ASCs. This is Mackenzie Bean, Managing Editor at Becker's Hospital Review, and on behalf of Becker's Healthcare, I just want to say thank you all so much for joining us today. Before we begin today's session, I just want to walk through a few quick housekeeping instructions. We'll begin today's webinar with a presentation, and we'll have time at the end for a question and answer session. You can submit any questions you have throughout the session by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link used to log into today's webinar to access the recording. If at any time you don't see your slides moving or you have trouble with the audio, please try refreshing your browser. Otherwise, you can also submit any technical questions into the Q&A box as we are here to help. And with that, I am so pleased to welcome today's presenters. First, we have Susie Cunningham, who is the Administrator at Advanced Ambulatory Surgery in Redlands, California. She has nearly 2 decades of experience in healthcare, first starting in pharmaceutical research, and joined AASC a little over 5 years ago. Susie told us that every day she comes to work ready to learn something new, and she usually does. Next, we have Dr. Martin Quigley, who is board certified in obstetrics and gynecology and reproductive endocrinology, and he has over 20 years of experience in clinical medicine, primarily at academic medical centers. He's also well-versed in health plan and managed care administration and is a site surveyor for the Accreditation Association for Ambulatory Healthcare. Brian Williams has 20-plus years of acute care executive management experience with direct responsibilities for infection control, performance improvement, and staff development. He currently serves as the Vice President of Compliance and Regulatory Affairs for MedTrainer, which includes serving as the Chair of Accreditation Advisory Committee. His latest work includes MedTrainer's Lab Comply program, which leverages the platform to improve CLIA compliance in healthcare organizations. Steve Dunn is Senior Segment Manager of Ambulatory Surgery Centers and Orthopedics at McKesson Medical Surgical, which offers medical supplies, healthcare solutions, distribution services, and clinical resources to healthcare organizations nationwide. With that, I just want to say thank you all so much for being here. To our speakers, and Steve, I'll now turn the floor over to you to begin the presentation.
Thank you, Mackenzie. And before I jump in, I have a little housekeeping for myself. You'll see that we're not showing a lot of graphs or charts in the presentation today. In fact, you can think of it more as a podcast with some visual guideposts as we move along. So you won't miss a key graphic if you get up to grab some coffee or your lunch delivery, as we're all working from home these days. But not only will you get the recording of the conversation, as Mackenzie said, you'll see links off to the right to some of the resources that we reference. And I'll also send you additional information on several of the things we refer to, including specific studies mentioned, and of course, feel free to reply back to me via email with additional questions. So the decision to add in-house testing to the list of services ASCs provide is a subject of lots of contemplation and even spirited debate. Several opportunities, such as the ability to better counsel patients and enhance outcomes, gaining better control of test results and increased accuracy and efficiency, have to be balanced against challenges including license requirements, training and compliance, personnel qualifications, which tests to offer, and myriad other considerations that we'll cover. We thought the timing is right to continue this long-standing conversation for a couple of reasons. First, the pandemic has put point-of-care testing front and center in all of our minds, much more than any of us would like, I think. And we're still navigating that together, both as an industry and a society. And secondly, as more and more procedures are migrating from hospitals to ASCs, the conversation is more important than ever as we strive to bundle and manage services across episodes of care and enhance outcomes and financial results. We have a number of specialty types and geographic regions represented on the call today, so we're going to keep the conversation relatively high level and national in scope, given that specialty type and state and local conditions and requirements can vary significantly. Now that said, we will zoom in a little on office-based labs, or OBLs, and orthopedics at the front, because we're seeing significant trends with important implications in these specialties. And we know many of you are working to identify new sources of revenue. As you know, many ASCs are choosing to run hybrid models, operating as an ASC on certain days and an OBL on others, and that's fueled by increased prevalence of cardiac and vascular-related disease states, and of course, CMS recently approved about a dozen cardiac cath codes for reimbursement in ASCs. And we all know that we're in the midst of an orthopedic revolution for surgery centers, with total knees approved last payment period and total hips just approved this year. So we'll start with some of the benefits and opportunities of in-house testing. Then we'll cover some of the challenges of operationalizing additional screenings rather, and then we'll cover some tips to help overcome them. So the key question to ask when determining whether you should perform certain tests in-house is, can I dramatically improve the quality of patient care by knowing now instead of later? And maybe a close cousin to that question is, can I safely perform this procedure on this patient in the absence of certain screening results? And what does it mean to the patient and to the business if the answer is no? In other words, will a treatment plan be modified or postponed based on what you learn from having test results available the day of surgery? And if the answer to this question is yes, then we need to determine the scale of testing, from certificate of waiver to perhaps moderate complexity, depending on your circumstances, and of course a plan to implement. Although we realize that moderate complexity may not be viable to do in-house for some, and we'll talk more about that later. So, as we touched on briefly, point-of-care testing in ASCs can bring several opportunities, such as the ability to better counsel patients and enhance outcomes. And some of these opportunities, of course, come in the form of reduced risk. So we know that 7 of the top 10 causes of morbidity and mortality can be detected via wave screening. And most of the lab monitoring tests associated with those screens are also waived. For example, BNP to screen for heart disease, some electrolytes to screen and monitor for chronic lower respiratory disease, some D-dimer PT-INR to screen for recent strokes, glucose and A1C to screen for diabetes, and creatinine and blood urea nitrogen to screen and monitor for kidney disease. I was talking to a customer recently who has lots of patients who have never been to a doctor prior to their need for surgery. So some of them are unaware that they have any host of conditions and even chronic disease states in some situations. So of course, she stratifies risk based on known patient factors such as pre-existing heart disease or high BMI, but the ability to test the day of surgery has significantly reduced risk across a variety of patients and conditions, from iron deficiency to pregnancy. And in fact, she actually has had the opportunity to deliver the big news to a couple unexpected patients. So before scheduling the surgery, she orders, as many of you likely do, EKGs and some moderately complex tests from her clinic referral partner based on her stratification method, and then screens for many of these conditions the day of surgery. including testing blood glucose pre-op and then post-op before PACU, and hemoglobin if certain risk factors are present. So I'm going to turn to Susie. Susie, you have an interesting story or two about the day of testing and some risks that you've avoided. Can you tell us about that?
Absolutely. Thank you, Steve. Well, we do regular testing of patients day of service, as probably many centers do. Some of the tests are drug screens, pregnancy tests, as you mentioned, glucose, HemoQ, and this past year, of course, with the pandemic, we've added COVID testing. And all of these tests let us know if it's safe to perform surgery on that patient on that day. We have a surprising amount of patients who, I think drug screens, I've always been really surprised at how many positives we have gotten on the date of service. But our nurses are excellent, and they can usually spot somebody who's under the influence, and we will, the doctor will order a drug screen, and we will cancel that patient if they come back positive. So that is something we use probably not every day, but every week. The COVID testing capability has been a game changer for us. We have, as everybody did, back in March and April, we canceled elective cases, but we were still doing stat emergency cases for the local hospitals, and to leave them available for COVID patients. And so testing was really the only way of knowing if we could keep our goal in the midst of all of it was to be able to provide a safe environment for our staff, for the providers, and for the patients. And so with that goal in mind, other than wearing masks and washing your hands, we wanted to be sure that the patient wasn't positive for COVID. So we initially had started sending those out to the lab, but that is very time consuming, and we can't get the results back. The busier or the stronger the pandemic got in our area, the longer the lab results were taking. So we were able to get an analyzer and test date of service for COVID. So that was a game changer for us.
Yeah, thank you for that. We're going to go a little bit deeper on your COVID journey and how you worked with your colleagues and even the board. I believe it was a board of trustees, if I remember correctly, in implementing. But before we do, so you're doing some orthopedic procedures, correct?
Correct.
Yeah. So I want to go a little bit deeper on orthopedics for the time being, and then we'll come back to COVID and specifically what type of COVID tests you're doing and some of the implementation factors. But so I know that orthopedics is important to many of the listeners, especially as you plan for adding joint procedures. There are several people on the call doing orthopedic procedures and looking to add joint procedures. So I wanted to compare or share some compelling research findings in case this is of interest to the listeners. So first, based on a study published in the Journal of Clinical Orthopedics and Related Research, surgical site infections are the most common indication for revision of total knee arthroplasty, and the third most common for total hips. Number two, according to another study published in the Journal of Arthroplasty, the risk of infection for knee and hip replacements is expected to increase 198% by 2030. That study and another estimate that the cost of post-op knee and shoulder infections will rise to more than 1.6 billion in the same time frame by the end of the decade. So why do I bring this up? Why is this relevant to a lab conversation? Because according to research published, again, in the Journal of Clinical Orthopedics and Related Research, suggests that the risk of surgical site infections increases up to 9 times due to nasal colonization of staph. And 30% of people are already nasally colonized when they reach the OR. And lastly, according to a study published in the Journal of Clinical Microbiology, you can trace as much as 80% of wound infections to the patient's own nasal flora. So the likelihood of surgical site infections due to nasal colonization is relatively low as a percentage of total cases, but the magnitude of the risk occurring is quite high, of course. The very least of which is a successful revision that will eat up your profits and cost you patient satisfaction and word of mouth. And of course, we know that the magnitude can be much more dire than that. So say, for example, you're doing 2,000 cases a year and your MRSA-related infection rate is, say, 1/3 of 1%, you're still talking about 6 or 7 incidents, which can have a devastating impact. Now, if you're doing total joint procedures, in all likelihood, you're ordering MRSA tests when you schedule the surgery, but we know some centers are also testing a second time on the day of surgery for colonization that can occur between the initial screen and the day of surgery. I'm gonna pause here for a second and ask everyone to go on mute. There's some really loud background noise. There are rapid testing platforms to accomplish this, and they start quite small, about the size of a large desktop printer. Now, whether it's financially viable and clinically appropriate depend on your unique circumstances, case volume, licensure, affiliated facilities, your specific payers and bundles, and the prevalence of MRSA in your community at any given time. And you'll see a link to case studies and tips on reducing SSIs, including MRSA and total joints, and the studies I referenced off to the right and on mms.mckesson.com. So before we go any further, I wanted to ask attendees this key question. I'm curious how you would answer this statement. My colleagues and I are on the same page when it comes to the costs and benefits of doing more labs in-house. And Mackenzie, any instructions on how attendees answer the question, or is it self-explanatory on their end?
Yeah, the poll should pop up and they'll be able to submit their answer. And then once you hit the next slide, we should see those results.
All right. I'll give it a minute. Looks like we're at about 1/3 of attendees. Let's see if we can reach the 50% mark. And 40%. All right, attendees. Provide your answer. Okay, we're at 45%. Let's call that good enough. Chomping at the bit. Okay, so about a quarter of you answered yes, that you and your colleagues are on the same page when it comes to all of the costs and benefits of doing more labs in-house. More, about approaching a third, 27%, are not on the same page, and a third of you are unsure. Hopefully we'll be able to clarify some of that if you're on the call with your colleagues today. All right, so before we bring Susie back in, I wanted to share what our customers tell us about managing outside lab orders. It's one of the areas they react most viscerally to, and I'm going to share directly from them in their voice. So staff feel overwhelmed, stressed, and pressured by the amount of work involved with ordering and tracking outside lab tests. And they tell us the lack of integration with their EMR creates extra work and makes them very anxious about labs in general and potential errors in particular. They need to manually go looking for charts and to reconcile lab reports to orders. It's often difficult to determine where tests are and where the results are in the system, which are missing, and because often there are no notifications to track. So assuring that results are communicated and all abnormal tests have been reviewed and shared is arduous and time-consuming. And lastly, what they tell us is that the hectic pace makes it easy to overlook labs, miss labs, and forget callbacks, and forget to confirm results. So there are tools to help with connectivity, and the ability to run just some basic urinalyses and blood screens at the point of care can have a big impact. So if this rings true to you and your colleagues and you're concerned about staff morale and burnout, let us know and we'd be happy to explore solutions to help you get out of the weeds and get back to patient care. So Susie, I want to bring you back in. I cut you a little bit short there, but efficiency and profitability is one thing, but you started to tell us about necessity in staying afloat during the pandemic, which is something else entirely. So many centers find themselves still or again in the midst of closing or reopening in some form or fashion due to the pandemic. So I think going a little bit deeper on your journey will be of value to listeners. So you had started to say that you were sending COVID testing out. You're in California, and I believe you were sending them to Texas.
That's right. So our goal, like I said before, was just to be able to continue the center's operations. We wanted to be able to continue to serve the community. When we stopped doing elective cases, we had the local hospitals sending us their traumas so that their hospitals were available for emergent cases that came in that needed to be taken care of, and for sick COVID patients. So that was our end goal initially, was to just provide a safe environment for the patients, for the staff, and for the providers. So in order to do that, we implemented the testing. But as COVID cases rose in our community, we weren't getting our lab tests back within 5 days. We initially had contracted with a lab in Texas who would, there was no cost to us to run the test. They billed the patient's insurance. So it wasn't cost prohibitive to do this. And as long as we could get the test results back within about 5 days of their date of service, everybody felt safe. Unfortunately, that started running 6 days and 7 days, and or you'd have a a child with a fracture come in, and the team would have to make a decision: do we risk this patient having COVID in order to provide, the fracture care that he needed? So it was a little scary for the staff initially. So we knew that we needed to secure a faster testing mechanism, and it needed to be accurate. And we luckily have a great McKesson rep who was hunting that down for us and giving us all kinds of options of companies who were working on analyzers that would give results, at the point of care. And so I believe it was probably middle of May that we got our analyzer, and we were able to start testing patients on the data service. So we actually still can continue to send labs, or the provider sends the nasal pharynx test to the lab in Texas, but we have the ability for any stat case, or if the results don't get returned to us within a 5-day, which is what our policy reads right now, we can do a data service COVID test. It has been a game changer for us. Again, the goal of keeping everybody safe and not, you're having people come in your facility, and you just need to make it as safe as possible for them and for the people who work there. So it helped us do that.
Great. Thanks for sharing that. So one lesson learned could be the need for certain tests for emergency preparedness. In fact, Brian and I were just talking recently about the fact that there's a shortage of trained lab professionals. And then so as we're in the midst of this pandemic, so self-sufficiency and business continuity may also be a factor to consider as we're weighing the pros and cons. So I promised to talk more about office-based labs. And so, the reason for that is, again, we know that many of you are looking to add revenue streams and services, new service lines. And there are a number of factors behind the growth we're seeing in the OBL market. So the first is very favorable physician payments. Reimbursement is driving site of service decisions, and ASCs strategically expanding into this growth area. So knowing this is on the radar for many of you, or maybe will be soon, I wanted to share a couple things to consider about this very lab-centric space. First, CMS now reimburses for vascular procedures and several non-acute cardiac interventions. And the favorable physician payments I mentioned in the ASC/OBL setting compared to hospitals are significant, ranging from an 8-fold difference for an angioplasty, for example, to up to a 28-fold difference for an implantable defibrillator. Second, several of the recommended testing protocols for peripheral vascular procedures, venous procedures, coronary interventions, and cardiac rhythm management can also be done easily and at the point of care with results available in minutes and integrated with your EMR if you choose. So if you're exploring a hybrid ASC OBL scenario, as many are, let us know, and if you'd like to be connected with an expert who can help you explore that space. So we all know the answer to the question of whether a treatment plan will be modified or may be modified based on what's learned from having test results available immediately is often yes. But we also recognize many primary care facilities in general, not just ASCs, don't provide in-house testing for a variety of reasons. So including a perceived lack of time or physical space to do the tests in-house, that the center staff are care providers and not lab professionals, not having the right lab license, the fact that you're already subject to a daunting volume of regulatory oversight and don't have the resources to keep records and manage inspections, lack of financing to purchase the equipment, and then lack of financial viability in general. Or I shouldn't say lack of, but the weighing the return on investment of all of the financials, which include, of course, reimbursement. When many times we're faced with weighing the cost of adding a test to screen for relatively uncommon disease states that might not be reimbursed, even though, as I shared with the surgical site infections after total joints, the likelihood is maybe small for some of these disease states, but the magnitude, if it does occur, is paramount. So let's bring Brian Williams and Martin in to help. So Brian, I'm going to start with you, and Martin, definitely chime in as you've got insights to share. I know you have many. So Brian, implementing new tests and testing equipment brings us a specific set of patient and safety implications to be aware of and manage. Help our listeners understand some of the most important things to consider when it comes to patient and staff safety, training requirements, and best practices.
Thank you, Steve. There are several. And it starts with understanding the manufacturer's instructions for use. And so quite often, a location will get the piece of equipment, point of care testing. It'll be demonstrated. They'll watch a video supplied by the manufacturer, which are generally very thorough, but it doesn't necessarily cover all of the topics in good laboratory practices. For example, the staff should be trained to discuss the test with the patient, what they're testing for, what they should expect, any apprehensions that they have. They should be trained to understand, read, and interpret the instructions for use, because there are certain quality control, monthly tests, first tests that should be supervised, et cetera, that should all be documented, none the least of which is noting lot numbers and expiration dates, which is often missed. And so the big thing on training is making sure that it's to the manufacturer's specifications, which may be different, applying good laboratory practices, and even though it's not explicitly required with CLIA-waived testing, competency review is critical and often is required by accreditation organizations. With that, making sure that they can perform the test safely, record the QC, and identify when there's a problem or a expired reagent or kit, and having a very integrated approach to setting that up with the staff is extremely important.
Thanks, Brian. Martin, anything to add to that?
Well, I think I'd just jump in and maybe take a couple of steps back. I think there are two different types of point-of-care laboratory testing that we're discussing today, and I think we're mixing some of them up. First of all, and this is done by virtually all the surgery centers and office-based surgery facilities, are laboratory testing required for patient safety and quality of care. And I'm talking about things like glucose by glucometer for diabetics. I'm talking about urine pregnancy testing for reproductive age women who might be exposed to midazolam. I'm talking about INR testing for vascular procedures such as deshunting, declotting, hemodialysis shunts, that type of thing. And I think those are the expectations that is part of the ASC's basic services. Then the other thing that we've just sort of introduced, and I think I'm getting a little confused, is expanding to the type of testing that's generally done through the surgeon's office through the primary care physician's office. This is part of the medical history physical. And I think those two are very different. I think the administrative challenges, I think the required licensure and certification, I think the type of personnel, and I think the reimbursement is different for that latter type of testing.
Thanks, Martin. And you're fading a little bit in and out. You started clear, and as you started to speak, you got a little bit muffled there at the end. I don't know if you.
Well, let me try and get rid of my earbuds here and see if it gets.
There we go. That was better just
okay.
now.
Okay.
So.
Anything you want me to repeat?
No, I think we got that last piece. And there's also a layer of quality control and compliance requirements that we started to touch on. And here too, first to Brian and Martin chime in. What can listeners expect when it comes to quality control and compliance requirements? I know that it can seem very daunting. I also know that some people are surprised at the number of steps and that need to be both taken and documented. What are the most common pitfalls you see when it comes first to quality control, and then let's touch on Martin in particular, accreditation and compliance shortcomings?
Well, let me jump in first, and this is purely from an accreditation perspective. Again, what we're looking for, and we're talking specifically about CLIA-waived point-of-care testing here, is that the surgery center is performing the testing in accordance with the manufacturer's instructions. So if the manufacturer says that the glucometer strips expire 120 days after the vial is first opened, you have to have a process in place for dating your strips and not using expired strips. If the manufacturer's instruction says that you have to have quality control testing using external standards done every month, every batch of new reagents, every new operator, then you have to document that you were doing that testing and that your results are within the range. And lastly, one of the things that we often do not see during the accreditation surveys is it's a requirement that you have the manufacturer's instructions at hand. That includes the operations manual for the glucometer, as well as the package insert for the test strips and the control solutions. And very often, those won't be there. And the very last thing is we expect in the personnel records that you documented, at least on an annual basis, the competency of the personnel who are performing point-of-care laboratory testing.
And to add to that, Martin, thank you, because that goes hand in hand with some of the other findings. When a supplier reagent or kit is expired, there's generally no alert to a supervisor or practice manager when the QC tests don't come out as expected. Again, you're depending on the personnel that are busy to report that in a timely manner. It often gets put into a report that's viewed after the fact. And so some of the things that I see as needs for this particular type of testing is a place that you can always find the manufacturer's instructions for use, and that your training includes the manufacturer's provided videos, which is quite common, and inserts and updates, but also training for good laboratory practices. Everything from bloodborne pathogens to proper documentation and informing others of the results. The other thing I would add is the QC is often monitored in the equipment itself, so self-contained. It does have the ability, many of them have the ability to export that information, but my observation is that many places just have a secondary log, and that works. I mean, it does work, but it's cumbersome. And if you're the person who has to assemble the quality assurance reports, it's not easy to spend all that time looking at this data and then finding trends and areas for improvement. So I certainly would suggest a more automated approach.
Just jumping in with one observation I find all too frequently on the surveys is that centers are performing the required quality control testing and putting a number in their electronic or paper logbook documenting they've done it, except their result is out of range and nobody engages their brain and doesn't notice that their quality control is out of range, and thus they've taken no action on it.
Yes, that's, being able to use real-time data to alert the right people to make the intervention. I mean, it may not be just the user's fault. They may or may not be reviewing what that range should be, what that reagent temperature was, a number of factors that need to be taken into consideration. When I read a manufacturer's package insert, they're usually 20-something pages long, and there's several different layers and steps. And so really distilling that down and helping the person who's conducting the test really understand all the facets, I think, are real key to making sure that when those things happen, that whether it's an automated alert or it's a physical alert, that they know when and how to do that.
All right. Thanks for that. So to sum up what I heard there, so Martin helped us to distinguish between, of course, moderately complex tests and CLIA-waived. With CLIA-waived, it's essentially following the manufacturer's instructions for use and having those instructions readily available for staff, and there's some other reporting and documentation requirements. Much more robust when it comes to the requirements for moderately complex tests, which is the verification of test performance, including precision, accuracy, linearity, potential correlation studies, depending on the test and the modality. So what we see then, of course, is moderately complex tests happening with an affiliated clinic or a referral partner, et cetera, and I see some questions to this effect, people in the care continuum that you partnered with for that bundle. Usually we're talking about a private payer bundle. Anything else to add on operational and compliance challenges, Brian and Martin? If you were to, for example, give your best word of caution, if you had to choose one common deficiency or one thing for listeners to think of as they maybe start this journey of adding more tests, do either of you have anything you want to punctuate?
I'm going to let Martin start, and then I have a comment about kind of things that are happening as we speak.
Well, I'll leave most of the time for Brian. I just want to make one quick comment that applies across the whole accreditation spectrum, and that is, if it's not written, it didn't happen. So you've got to document your quality control testing. Got to document that you've got the instructions. Got to document that your tests are within range. Got to document that your reagents have not expired.
And the first thing you said, Martin, is that if it's not written, it didn't happen. I just wanted to repeat that because you were a little fuzzy there. Yep. Okay.
Oh, certainly. Yes.
Brian?
Having been through many surveys, if it wasn't written and it can't be explained, is also another facet. It is one thing to be able to kind of follow instructions and so on and so forth, but for the staff to be able to explain what they're doing, why they're doing it and who they report it to. They have a problem I want to punctuate. But because we differentiated between CLIA waived and moderately complex, in our review we did find ASCs that do use moderately complex testing at their sites from it's an overall population of licenses issued. And some of the rationale and preparation for that, if you're really good at documenting how you work through the CLIA waived processes, getting the right talent on board to, whether it be a consultant or what have you, for the lab director responsibilities, can help with that transformation. It's all about documenting, testing, and quality assurance. That should be integrated in all of the lab tests, but also the results that are used for the patients. With the advent of, with what's happened during this pandemic, and we've seen the FDA with, lightning approvals for various pieces of equipment, testing equipment, et cetera, we can expect there to be much more in this realm from CLIA waived and moderately complex that will be very beneficial. So I would just say if you're not looking at these things, you should be, and if you are looking at them and they seem rather difficult and cumbersome, perhaps we can help simplify that and help you organize it.
But again, just jumping on to Brian's comments, for a typical surgery center, the personnel qualifications required for moderately complex testing are way above what you expect for CLIA waived. In other words, your typical RN is not going to be qualified to perform moderately complex testing.
One of the ways that the ASCs are dealing with that choose to do those type of tests is to use consultants, and we're not a consultant for that particular service, but to work with them over a period of a year to get that lab director experience required for that test. And one thing to keep in mind is it's important that you're looking at the types of tests and not trying to create a lab director for all types of tests, because certainly the complexity and cost would be prohibitive. But look at what would work best for your patients to improve outcomes, what you could reasonably implement and avoid risk, and at the same time maybe even improve revenue, or at least as we look at the way contracts are continuing to be bundled to distribute risk equally across all participants, might be a good strategy to at least have in your review of the benefits of these types of tests for your ASC.
Right, but it's not just the laboratory director. It's also the requirements for proficiency testing, the requirements for site surveys, and most importantly, the requirements for the qualifications and licensure of the individuals actually doing the testing.
Correct.
And Martin, forgive my ignorance here, but the need for a dedicated medical director when it comes to these types of tests, the non-CLIA waived, the moderately complex and complex, is that a requirement, first of all, nationwide, or are there differences by state? And secondly, is that true in all circumstances, even if listeners are adding just one or two specific tests, or does it have to be a full-blown, quote-unquote, lab to prompt that requirement for a dedicated director?
Okay, I'm looking at the CAP, College of American Pathologists, information at the moment. If you do even a single moderately complex laboratory testing, and a typical copy would be a typical example would be a woman's healthcare clinic that does blood RH typing. That's a moderately complex test. Your laboratory director
has to have MD degree or equivalent, in other words, a medical degree, has to have at least 1 year experience or 20 CME hours or similar experience in residency. So basically, that's a burden that most of your medical directors of ASCs aren't going to be interested in going through.
Mm-hmm.
So
okay, thanks for that.
I have a resource, Martin. I agree.
Yep.
First of all, I understand those qualifications, and I do have some information from CMS on how to effectively work through that. Some of that is external 20-hour courses and having the right consultants get you started up.
Well, you have to assume the medical director is interested in putting in the time to take the courses to get the necessary
Correct.
experience and training.
Yeah, we're going to assume for the sake of this argument that they've looked at it. It is a beneficial test, and what steps would they need to move forward? And Steve, we'll provide a guide for what those are and an easy reference for listeners today. I understand that it's not easy, Martin, and I also respect that some directors may not choose to do that. But for those that do, and some have, there's, I believe, at least 700 or 800 ASCs that I found that have moderately complex labs and for a purpose. And so our goal today is really to inform and provide resources if possible.
Thanks for that. And so we're rounding the corner here, and we want to get to some questions. But before we do, let's do another poll question, and then I have a couple more words, and we'll go to Q&A. So I think you see the poll question on your screen, and it is, I feel comfortable my center is always compliant with lab-related equipment and documentation requirements. So go ahead, listeners, if you will, answer that question, and we'll get to about the 40% mark, or maybe a third in the interest of time. Hopefully you can all stand the suspense. We're at about 25%. All right, we're at a third, so let's do the big reveal. So more than 50% of you feel comfortable that your center is always compliant with lab-related equipment and documentation requirements. Interesting and good news. About a fifth of us are unsure, and then about the same amount say that it's not applicable at this point. Maybe that's why you're tuning in. So I wanted to, there's a lot to think about when determining whether to add additional in-house tests, as we've covered. So I want to really briefly offer up 3 criteria to help you prepare: readiness, willingness, and ability. So we're not going to be able to cover all of this in detail, but we do have this information that I'm going to tee up here on mms.mckesson.com. And if you'd like, I'm happy to share more details. But first and foremost, we recommend defining your purpose for implementing additional tests, and to make sure that that purpose is clearly communicated to both staff and patients. So you might think of this as your lab mission. So the mission establishes a credible reason for performing these services and serves as a reminder of the importance of lab testing in the overall patient care mission. So for example, your mission might be as broad as to provide routinely needed lab screening, to guide development and modifications to treatment programs for our patients, or your mission might be a little more focused on a specific specialty or procedure. For example, the mission could be to be at least 10% below national benchmarks on surgical site infections caused by MRSA colonization. So being ready has many dimensions to it, of course, but determining which tests to perform is perhaps the most critical decision to start with. So a good starting point is to determine your core testing needs, and then evaluate, say, the last few months of tests sent out and select those you send out most frequently, determine whether they're CLIA waived or not, whether there's reimbursement, or whether you have partners in your specific private payer bundle to make sure that those tests are added to your care protocols. So some centers focus on the tests that can be performed and discussed during a patient visit, 15 minutes or less, including lipids, urinalysis, rapid pregnancy, respiratory, and some cardiac markers, as well as hemoglobin, A1C, of course. And maybe some of these tests can coincide with pre-op consultation or quote-unquote prehab visit if you're going that route for total joints, for example, as many people are. So starting with the core tests and adding more as your experience grows is a sound way to go about it. And we and our manufacturer partners, of course, have consultants in every region who can help you determine what testing platform is best for you, clinically, operationally, and financially, and can even coordinate demonstrations to help you select the right tests and technology. So once you've identified which tests you want to run, there are some facility-related readiness factors to consider, of course, but base considerations will be minimal for many of these wave tests done at the bedside, so to speak, as many of the test units are either handheld or small countertop profiles about the size of a large personal printer. And if you're using an automation tool that digitizes your training and compliance records, package inserts, operator manuals, safety data sheets, etc., your space requirements will be even less of a consideration. And I think we all know the 3-ring binder factor can get a little bit out of control. So I'm going to stop there, and I'll be sure to link to more information on readiness, willingness, and ability to test, to add tests, but I wanted to get to a couple questions. So Mackenzie, go ahead and tee us up.
Perfect. Thank you so much, Steve, and thank you to our other presenters for such informative thoughts today. Like Steve said, we'll now begin today's Q&A session. We've already had a lot of great questions rolling in, but if there are any other questions you'd like to pose to our presenters, feel free to submit those now by typing them into the Q&A box you see on your screen. So it looks like a lot of questions have come in asking about reimbursement. So would you not mind clarifying, can an ASC bill for lab testing? Are they getting reimbursement at this point?
That's a great question, and we are not getting reimbursed. There's not a mechanism in place by CMS to allow for a surgery center to bill for these. There is a couple workarounds. The workaround is having your provider do it. For us, we share a building with our provider group, and so they also have the ability to run the rapid test, and they often do that on our behalf. If we have a stat surgery scheduled and they haven't done the testing, we will do it at the data service. The cost to do it is nominal. We have just decided that that is the cost of doing business. So we can actually test a patient for under $30, and we just absorb that. So that's what we're doing.
And Martin, because we've got so many questions on reimbursement, we got one specific question about have any ASC successfully billed for any CLIA-waived services separately, in other words, not as part of a bundle?
Let me put my medical director hat on for a moment and my patient advocacy hat on for a moment to answer that question. Most ASCs are contracted with their payers, if they're in network, to provide service on a per procedure basis. In other words, they're not doing line item billing for surgery center procedures, not billing separately for a vial of propofol and a 4x4. So they would not have the ability under that kind of contracting arrangement to bill above for their laboratory testing. In fact, with the contracts between most health plans and surgery centers, they list the CPT codes you can bill for, and laboratory testing is not within the purview of an ASC as far as billing. Secondly, I think you need to think about what your patient's insurance may be. Now, if they're a traditional fee-for-service Medicare, it really doesn't matter. But if they are contracted with a Medicare Advantage plan or a commercial HMO, very often those plans will only have a contract with Quest or with LabCorp. And if you send your specimen to the wrong place, the patients can get billed 100-fold. And the payer, the insurance company, would see a surgery center billing for laboratory services on behalf of a patient as a out of network, and very likely would deny all reimbursement, which could open the patient up to additional huge charges.
Wonderful.
Thanks for that.
Both weighing in here.
Go ahead, Mackenzie. I was just going to ask, we're a couple minutes over and we've got some more questions. Are we going to be able to reach out to the specific attendees to answer their questions offline? Can we save the ones that we see in the chat?
Yeah, absolutely. We will have that opportunity to make sure people's questions get answered.
Okay. Very good.
Looks like we have time for about one more, though, we can fit in. This question is asking, at my center, we do emergent dialysis access procedures. Does anyone have any experience with this, and do you proceed without a COVID test?
I'll answer that from a medical perspective. I think you have to do what's necessary for the patient. And if the patient is asymptomatic and not exposed, I'd certainly go ahead and do it without the test.
I agree with that. That's what we would do.
But not if it's for a blepharoplasty. Yeah.
Perfect. Well, that is all the time we have left for today. Susie, Dr. Quigley, Brian, Steve, I just want to thank you again for such a great presentation, and thank you to McKesson for sponsoring today's webinar. To learn more about any of the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Otherwise, thank you all again so much for joining us, and we hope you have a great afternoon.
Thank you so much.
Thank you all for putting this together.